Good morning, everybody, and welcome back to this second edition of InterSystems webinar in Belgium. This time we are really happy to have Fadi Glo, our country manager for InterSystems Belgium. As you can see, you have different screen and different parts. So on the left, you will see the presenter. In the center, you'll see the presentation. You can go always in full screen. If you want, you can also ask your questions and we will answer them. We'll take them and we'll try to answer them at the end. And if you have any problem, we are also here to help. So don't hesitate to ask questions. The purpose is to be interactive, but I won't be longer, and I will give the floor to our country manager, Fadi. So Fadi, the floor is yours.
Thank you, Geoffroy. Thank you for joining us in this session about health data without borders. My name is Fadi and I have the honor of leading the operations here in Belgium for InterSystems. This session will be a session about what we can learn from how data is being addressed internationally. So yes, this is a presentation about digital health and AI. No one will fall off his chair when I say that this topic is very trendy. In fact, the European Commission published in January 2026 this 300-page document exploring Europe's digital health landscape. On page 27, on this figure here, it answered the question, why do we even bother digitizing everything in health? Why do we care? The answers are very unsurprising. You'll see in the answers that you can read in the screen that you recognize most of these things, and that these are goals that we want to achieve. These are goals that we want to achieve. These are boxes that we want to tick at InterSystems as well. The first one, offering better care. I can share an example of my own experience where I have a brother. Everything is fine with him. Apparently, he has an ibuprofen allergy. It was in his profile. It was in his health record, but nobody noticed it. So when he had knee surgery, they gave him a lot of ibuprofen to the point that he had to be readmitted in hospital because it created a perforation in his guts and he lost a lot of blood. If we have all that data and it surfaces at the right time, he would not have been given ibuprofen at the end of his knee surgery. The other thing that is interesting in this list is that a lot of people see that this is costing more money. The document even talks about 15% projected extra costs per year. But despite that, people see that we have to do that because it makes us more efficient and it makes us more productive. So that's what we want to do. We want to tick all those boxes. And I hope with what you see today, you'll have the confidence that you can get there in the context of patient data. The document also states that the biggest struggle in introducing digitalization is scalability, getting things from a pilot to reality, not just organizing data for one or two therapies, but for all therapies, not just organizing data for one or two hospitals, but for all hospitals in a region where a patient realistically comes. Not just for hospitals alone, but also for nursing homes and home care nurses. So today we want to give you confidence that this is indeed achievable. One more reference before I jump in. One more reference. This one is more specific about using AI in healthcare and where it is used for what kind of applications. You see here a top 7 of applications where AI is being used in the European region. AI-assisted diagnostics is leading. Today, what we will be talking about more falls into the 3rd bucket, administrative and logistic automation, and in the 7th bucket, remote patient monitoring. So let's jump in. The context of today is the EHDS. The EHDS, as most of you know, is the European Health Data Space. It's European legislation that wants the patient's data to be available to the caretaker, no matter where the caretaker is in the European Union, and also wants the patient's data to be used for research in the search for innovative therapies. Now, if you like that, I put a screenshot of the legislation in there. You can read the legislation if you're good at that. You can also read the vulgarized dummies guide that I published on the peer-reviewed platform called LinkedIn. That's the little screenshot on the bottom left. Or, and that's actually what I would advise you to do if you're a Belgian, you can go to the website of the HDA, the Health Data Agency, who did an excellent job explaining that legislation in 2 cartoons. I'll show you the 2 cartoons in a second. The content of my presentation today is also published in another peer-reviewed article called The Dummies Guide for Hospital Alignment with EHDS, and that's the screenshot you see on the right. But first, let me share with you those screenshots from the website of the HDA. They exist in Dutch and in French. I have the Dutch screenshots here, and they explain that this guy called Alex is heading to his holiday destination in France, but on his way there, he has an accident. He's unconscious, and he's picked up by a hospital in France. He gets into the emergency room, and in the emergency room, thanks to EHDS, they realize, hey, this Alex guy is diabetic. And because they realize that, they're able to give him the right care. That's primary use. That's making sure that whoever outside of your own member state is confronted with you and is taking care of you has access to your record. Primary use of data. It doesn't end there. It doesn't end there. There's also something called secondary use of data, and that's where the data that is generated for Alex goes into a pool of data for all diabetic patients. And by looking at how these patients are treated, we can start looking at new therapies, start doing research, start being innovative with that data. That data becomes available for innovative use, and that's the secondary use of data. The good thing about the EHDS is that by default, your data is available. You can step out if you want. You can say, I don't want my data to be used for research, but by default, the European legislation is making your data available, in this case, Alex's data available for diabetic research. Now, there's timelines for that. We're in that timeline. The legislation is in place. You'll see that there's timelines for primary use. That's the blue part. So that's the part where the doctor that sees you outside of your member state has your file at hand. That's the blue part. The red part is the secondary use. So there is a timeline for researchers that they should be able to start getting access to such data. Now, what's interesting, you also see a green timeline in there. You see a green timeline in there because the electronic health records are expected to comply with this legislation and make their data available. Now, some of you now may think, hang on, if the electronic health records have deadlines and have responsibilities as well, then I don't need to do anything, right? I can just sit back and relax until the electronic health record gets everything ready for EHDS. If only it was that simple. What the EHDS will do is create the rules, explain what needs to happen. The EHRs will do something for you. I'll go through what you can expect from the EHRs, but they won't do everything. So if I take the metaphor of a handrail, if you expect the handrail to be created for you, it will be a disappointment. The rules for how to create the handrail will be clear thanks to EHDS. But in the end, you'll be expected to work with your preferred partners and have that handrail created yourself. What does InterSystems know? InterSystems is a company that was created close to 50 years ago. At the basis, it was a database company. It became really quick an interoperability company as well. And the vertical in which InterSystems became the most prominent is the vertical of patient data. When you look around the world, today it is claimed that 1 billion patient records, 1 billion patient records, not 1 million, 1 billion patient records are in one way or the other managed in InterSystems technology. It doesn't mean that InterSystems has access to those data. It just means that the technology that holds that data is InterSystems technology. When I look at the Belgian scale for this, the Belgian footprint, that technology will be recognized will be found in packages like that of Epic, of Zorgi, but also in lab packages like Mooly's and Data Innovations. For the anecdote, if I stick to the Belgian perimeter, the biggest user of InterSystems in the Belgian perimeter is the federal police. Because yes, if you're a Belgian and you get stopped along the road and they're checking your breath for an alcohol test, in the background, a lot of tests are being done at the same time. A lot of tests are being done at the same time, like are you not a fugitive? Shouldn't you be in jail? Is your car not stolen? All that kind of checks is done in a rapid fashion. As you can imagine, this is very sensitive data. And that's one of the places where InterSystems in a Belgian context is found as well. Primarily, patient data is what InterSystems takes care of. Outside of Belgium, InterSystems is also a supplier of EHR systems. In fact, we take pride in the fact that InterSystems is the first supplier of an AI native EHR system, which has MDR Class 2 certification figured out. So yes, all that does put InterSystems in a certain position where we can advise on what you can expect from an EHR, and you can expect a lot, but not everything in the context of EHDS, and what still remains to be done by hospitals and regions who want to comply with the EHDS regulation. So what can you expect? I'm showing you a couple of screenshots. This is a situation where a patient gets admitted to the ER, to the emergency room, and everything that happens in the emergency room is recorded. That's what you see on the left on that phone. Everything that happens in the ER, all the ambient noise is being recorded. Obviously, that comes with a lot of advantages. You can afterwards see a transcript of that, and of course, you can have a summary of that you can push into your report. It goes beyond that. In this screenshot, you'll see that the AI will have picked on certain activities that happened, activities that it can map to a SNOMED code. So it tells you, all right, so it helps you in your codification immediately. Yeah? So this happened. These are the things that the AI thinks that happened when that patient was admitted to the ER. Not just that, it will even suggest, that's what you see on the bottom of this slide, it will even suggest next actions that you can do on this patient. When the patient gets then handed over to the ward, the AI inside of your EHR will write a report, a handover report that the nurse can use to take the patient in charge. It's also full of advantages for the patients themselves because it comes with a patient app. All modern EHRs have a patient app, and explaining what happened to the patient becomes a lot more easy because you can now also do it in the language of the patient. The patient can also converse with that in that app with the app to understand what's happening to him or her and how he or she should get ready for the next step in his therapy, and it all happens in their own language. You see it at the bottom right here, a coding assistant, which will help you code everything that happened in the hospital, so you get well remunerated for what you're doing in the hospital. In this case, it's ICD-10, but it could have been SNOMED if you're working in a Belgian context. CPR documentation, in that sense, it's clear to see the advantages. This makes everybody, and that comes back to what we saw in the publication by the European Union, it makes everybody more efficient. So you can expect a lot of things, and it's not just that. Thanks to EHDS, what you can expect on top of that is that the data that for years was closed and inaccessible in your EHR systems will now be made accessible. So, the EPD providers, the EHR providers, are expected to make their data accessible in a format, the FHIR format, which will allow you to unlock the data that is often a problem locked now in the systems. So when you listen to all that, you may think, well, great, the EHR will actually solve everything. And that's where we have to put a caveat. There's a number of reasons why you can't rely entirely on the EHRs. Let me give you just two reasons. One of them is if Alex, that patient that we were talking about, is in France, what you don't want is that French surgeon or anybody in the world to be able to query you immediately on your EHR. That's not what you want. Another reason is not all the data is in your EHR. Even hospitals with the most complete EHRs will have data to share that is outside of the EHR. So those are just two reasons why you can't expect everything to be solved by the EHR, and it leaves a certain responsibility on the data holders, on the hospitals, to unlock the data. So how can we unlock that data? What you see in this slide, on the left, you see a representation of the different databases that you have in a standard healthcare delivery facility like a hospital. The one in blue at the top is your EHR indeed, and you'll see that there's other databases that you will want to unlock. Lab results, administrative data, sometimes softwares that come with the medical devices that will contain data. National services. When I look at the Belgian reality, this can be COSO, this can be Abrumed, these can be vaults that contain data that you want to have access to. Historical data, especially when you change in your EHR, sometimes the historical data is not fed into the new EHR, so that one is still there, sitting there, and you want to have access to it, etc. What you'll typically do is you'll solve it through interoperability, through an enterprise service bus. Now, what that does is it connects everything to everything, which indeed offers some kind of solution. Now, it comes with limitations. Limitations are listed on the right of this slide. It soon becomes complex. It soon becomes costly as well, because EHRs will often charge you for every connection that you want to do over there. In the second bullet point, you'll see that not all data is structured. Data is often locked in documents, in PDF files, in free text. How do you make that accessible? Often you end up with caregivers needing to switch from one application to the other. The other thing that is not straightforward with this is when you want to start using that data for management purposes, what you really want to do is you want to feed that into data lakes where you can then create cubes on it that you can research and get your management reporting from. It's not straightforward to do that with such a setup. More and more, we hear from hospitals in particular that they want to do some real-time monitoring of their hospital. It's difficult to do that with this setup. And then the legacy data is a remark I already made. The metaphor we use for this setup is that one of the hazel shrub, where everything is connected to everything. At the bottom of this metaphor, you see the different databases that represent your roots, roots, and then at the top, the leaves is what is the goals that you want to achieve with the data that is inside of those databases. And when you start connecting everything to everything, you get a splendid hazel shrub. It's a beautiful type of tree, but very difficult to manage. So how can we solve this? Let's see how other countries are doing that. Maybe first let's look at France. Not that France does it so fantastically well. Depending on the regions, you'll get good regions and regions that are a bit less well organized. But they do have a splendid theory. And the theory is the one in this slide. What you see here is, again, your database is on the left. Your service bus is still required to make sure that everything is unlocked. But then you see a database symbol in the center. And what you'll do is you'll centralize your data in that central database. Now you can copy it, you can make a copy of your data, or you can keep the data in the original databases and work in a federated fashion, as long as you have your metadata over there so you know where to search, then that works out. So you see that database symbol in the center, that's what we want to achieve. You can, in that database, keep your patient data, but not just your patient data, also your data you need for the management of your hospital. To get there, there's a number of things that that end up being your responsibility, and those are the ones you see in the purple box and the purple pentagon on the left. You have to be able to aggregate data. You have to be able to work with different formats. HL7 for messaging, convert it into FHIR, or take all kinds of formats and bring it into that central database. You have to be able to distinguish patients. Is data that I get from two different systems, is it from the same patient or not? So some kind of master patient indexing will be required. Terminology mapping. A blood pressure in one system may not be exactly how the blood pressure in a different system is identified. So making sure that you have your terminology right is required. Once you have all that, you reach the goals that you see at the right. At the right, you see the word patient, for instance. You can unlock that data to make it visible to a patient. You can unlock that data to make it visible to a caregiver. You also see the symbol of an API at the top. Once your data is there, what you don't want is to have it locked in there. This has to be an open system with no vendor lock-in, because when you achieve that, you can, with APIs, start accessing all the data that is in that centralized or federated database and make it available for all applications that you want to use downstream. This is primary use. You see the words research and management. So it's also useful for secondary use. Research means it starts feeding your clinical studies. Management means you can start issuing your management with reports about how your hospital is doing. And this can be as simple as, do we have at any time of day enough wheelchairs on the parking lot? But it can also be as pushed through as how is my hospital doing compared to other hospitals in the care of this particular type of patient. Now, to get there, you see another pentagon on the right with tooling that you would need to have that to make sure that this happens in a safe fashion. If I go back to the metaphor of the hazel shrub, what you're actually doing is not designing a hazel shrub, but you're designing an oak tree, where the databases, again, are at the bottom. They form the roots of your oak tree. You create some sort of central repository where you either stock or reference the data. You'll do that a lot with the FHIR format, but not only the FHIR format, because it would be naive to think that everything will be made available in FHIR. Everything can be made available into FHIR, but it would be putting your bar too high if you only want to do it for data that is converted into FHIR. So be welcoming for data formats like SQL or others. And once you have that, you can reach the 4 goals that you see at the top. Those are represented by the 4 branches. The branch that goes to the right is your secondary use branch, where you can also convert data into typical research formats like OMOP. You will not start from the databases, you will start from that central repository. The blue branch is your primary use outward. That's making sure that the data that you have in your systems for one particular patient is fed to whoever has that patient in front of him at that moment. That's primary use outward. Management use, that's what I said about the wheelchairs and comparing your hospitals to others. And primary use inward is a branch that works in the other direction. Just like sugars get created in the branches and pushed back to the roots. What you see here is a connector, something that connects you to the outside world, to make sure that whatever data is generated for your patient transmurally, so outside of your hospital or in a different hospital, gets fed back in, not straight into your EHR. That's a typical Belgian reaction. Let's push it straight into our EHR. The best practice is to push that into a central repository, and from there, visualize it in your EHR, or feed it into your EHR if that's what you want to do. So that's the metaphor of the branches. The Germans take it one step further. The Germans take it one step further. They take an academic approach. What they do is they will organize around the academic hospitals networks like these that not only contain the data of the university hospital, but also the data from all the hospitals referring to them. And not just the hospitals, but also the first line. So the doctors and the nursing home around them. What you get then is the same slide, but instead of having that database connected to the databases of one entity, it will be connected to different entities. Entities that are hospitals or primary care units, GPs, nurses. And when you do that, the continuum of care becomes possible. In this example, I'm on the right of the slide now. In this example, I'm a patient connected to this system. I get a questionnaire, and based on that questionnaire that I fill out, I get a warning. Oh, there's probably a good reason to go see your GP. I go to my GP. GP has access to that same data. The GP is well informed before I even enter the consultation. And based on that consultation, based on a conversation with me, he says, yeah, maybe indeed it's worth that you go for a test in the day clinic. So then you go to the hospital where the day clinic is, you have your test done, they have your data already over there, and you see what's happening. Everybody in this continuum has access to the same data and can take care of the patient without having to redo the entire story with the patient and without the risk of forgetting important information. And the story goes on. Once you get back home, if you need follow-up from home nurses have the same data available. And that's how you create, that's how German friends create a continuum of care. I'll skip this slide and I'll skip this slide as well to be able to show you what this then in the end looks like in reality. And let me, to do that, share my screen so I can share a video with you. I'm double checking to see if the video has loaded and if you guys are seeing a video. I'm assuming you are. So I'm assuming you're seeing a video of a patient called Mark Schilling. Mark Schilling has an overall view, and this is the overall view that we have created for Mark Schilling. You see all his diagnoses in here. You see his allergies. You see his diagnosis, lab results. No matter where they were generated, whether they're generated within the hospital or do they come from instances outside of the hospital, everything surfaces here. This is the clinical summary. On the left-hand side, you see that you can start navigating for more detail. In a Belgian context, what you see on the left are the care sets. And the conditions are your problem lists. Allergies are allergies. Medication would be VDs. Immunizations would be your vaccinations, etc. So in a Belgian context, that's the care sets that you see on the left. And you can now start digging in. I'm double checking to see for quality.
You need to share your screen if you share.
I'm not sharing my screen. Okay. If all went well, it means I'm now sharing my screen, which I wasn't doing before. So you're seeing in this screen the overview for patient Mark Schilling. All the data is in there, no matter where it comes from. If it comes from your own hospital or outside of your own hospital, and you can start drilling through. You can start drilling through using what you have here on the left, what we call the chart book, and all of these little titles are your care sets if I translate it to a Belgian context. So fantastic, it works. We have all the data available. What you also see is that by creating that, we've created a new problem, because when you bring together all the data, you have all the data together and it becomes a mess to find the information that you need in this multitude of information. That's where new tooling becomes very useful. What I've done now is I've hit the button on the top left, which takes me to my AI assistant. And in the software, like you see it here, we have a number of predefined reports. I'm going to give 2 examples. The first example is just the demographic report. The demographic report will just make a summary of your patient with non-clinical information. Who is this patient? Where does he live? Does he live alone? Is he insured? All that kind of stuff. You'll see a little button called See Sources of Response, because with AI, you always have to be careful and make sure that you know which data this is based upon. The provenance of your data needs to be clear. Now, the sources of data don't necessarily need to be structured. Sources of data can be unstructured. So what you've effectively done here is you've created a tool that takes your unstructured data in PDF files, in documents, and discharge letters, and you've structured it. And you can then, if you would want that, push that structured data back into your own system. Now, first example was non-clinical. I'm going to second example. This one is clinical. In this example, I'm a nephrologist, but I'm not necessarily the nephrologist that sees Mark on a regular basis, but hey, I'm faced with Mark. What I need from his profile is not everything, but just those things that are relevant to a nephrologist. So I hit the button, nephrology summary, same story. It gives me a summary of that patient and only of those things that are relevant for me as a nephrologist. Where this really hit home with me, we're getting there with the laboratory trends that you see at the bottom now, is that there's apparently 7 laboratory measurements that have been done in the past. And today, this would be opening 7 PDF files that are each have their own layout and start looking for the interesting value. Now I just have it put for the 3 values that I need as a nephrologist, the sequence, and I don't have to open a single PDF. You can see how this makes everybody more productive. You can start conversing with it. If you say this is too much, all I need is one particular value. Okay, you can hit the assistant with it and it will get you the right data. These prompts can be can be changed. The model that you use, you've seen we were using an OpenAI model for here, but if you want to use a local model, you can do that. That's what the hospital in Charleroi will be doing. They're using an AI model that runs in their basement. And what you see here is that prompt, that's where your IP will be. That's where you say, all right, when the AI looks at my data, I want to see this, and that. And this is how I want the report to be structured. That's what you're adjusting in the prompt. We also see the sources of data, because for something like writing patient-friendly discharge letters, you may not want to have all the data in the system looked at, but maybe you can just have it look at the discharge letters that are intended for the GP, and ask it to write patient-friendly discharge letters. So then you would not have all the data points connected. So, right, that's what it could look like, and that's what our German friends and other friends around Europe are using. If everything goes well, I'm back to the presentation mode now, and you see a screen that says that you can check out healthshare.be. Healthshare.be is a demo site where we have a Belgian version of what I just created. To request, log in and play around with it to see what this can look like. So great, Fadi. This works great for primary use. Does it also work for secondary use? Well, of course. Of course, it works for secondary use as well. I'm trying to go to the next slide. Well, it's not allowing me to do that. It works for secondary use as well, because once your architecture is set up properly, like we've shown here for primary use, it becomes a place that can manage your secondary use as well. It becomes a place that starts feeding your registries. You don't have to feed your registries. The record once principle is embodied by an architecture like this one. There you go. And this is an example of a diabetic registry. You can obviously do that for all the registries that you would want to feed, assuming the data is already registered once, for instance, in an EHR. There's a patient app for it as well, which is very interesting when you start connecting hospitals that have different EHRs, because each EHR typically has their own patient app. But when you connect different hospitals with different EHRs, it's good to have another patient app that contains the data of all these hospitals. All right, and what we ended up doing is what you see in this slide, is that we put the patient centrally and we start connecting the blue dots. The blue dots are the places where the data is stored, and what InterSystems will do, it will connect with those green lines the data so that we can create that central overview. Now, some of you might be thinking now, why is the government doing this? Why do we, as hospitals, as data holders, have to organize this? It's a political choice, and you can compare it a bit to the trains. You can compare a bit to the trains, because there also all member states have taken their own decisions. Do we privatize everything, or do we make sure that trains are state-run? Belgium is an example where tracks and trains are state-run, but there's other examples, you see it in the slide, where different choices have been made. And in this case, Belgium made the choice not to organize the patient data on a central basis. Other countries do it differently. When I look at the Dutch have it well organized. This is a picture that ChatGPT gives me when I ask him to draw a picture of the Dutch that have patient data well organized. And what they do is they organize data on a regional basis. So, and a region is if I make the comparison to Belgium, it's an arrondissement in Belgium. So in the regions, they do exactly what we see in this slide. They do exactly bringing all the data together, getting a general overview of that patient, and following the patient up, for instance, for diabetes follow-up. The Finnish have a similar story. And when I show this slide, I always make the joke that ChatGPT reminds us that there's a lot of reasons to be jealous of the Dutch. One of them is that the Dutch have two right hands. The Finnish do it more or less similarly than the Dutch. It's also on a regional basis that they organize this. In Finland, they have 22 regions with each one database for the secondary care. So the hospitals in one region are on one system. There were, until not so long ago, 308 municipalities with each their own databases for primary care. So all the municipalities were responsible for taking care of the patients locally and managing that data. What ended up happening, and I give the example of Pira, is that Pira is a region that has 500,000 citizens and 20 municipalities with each their own database. There's an extra database for the hospitals, and what they did is they created one unified care record on top of that, one longitudinal file on top of that. And that's what they created on a regional level. The interesting fact about Finland is that they started realizing that they maybe didn't need all those databases on a local level, and in the end they ended up with 3 EMRs instead of the 21 that they had before. I'm going to skip the Irish example, which is a very cool example because it created one file, one central file for the entire country. But we do see, the trend that we do see is that us as patients, we disseminate our data over a number of sources. Over labs, we go to different labs. Usually we stick to one GP, but it happens that we end up in a different cabinet as well. We end up in different hospitals. We disseminate our data over a vast number of sources. And then somebody takes up the governance, the responsibility to bring everything together in a unified care record, in a longitudinal record on a regional level. The different countries do it in different ways. but the trend is the same everywhere. That's where I often get the question, what does InterSystems do? Well, exactly that. Will be those green arrows here that you saw on the previous slide as well. The green arrows connecting the blue dots, and we'll manage that layer of a longitudinal layer for you. From there, you can take care of your primary use. You can start sharing data for primary use, but also start feeding registries and other databases for secondary use. The analogy that I can make for Belgium is the one that you have for electricity. Belgium will identify what the rules need to be. That's what that the care sets will be. That's what the Receive INAMI is working on. Just like with electricity, the government decides that we're working on 220 volt, etc. But then what you plug onto it and how you plug into it becomes a responsibility of the data holder. So what does that mean? If you're a data holder and you want to unlock your data, the responsibility will be, the advice that we give will be that you create that trunk architecture, that you create a central repository, and that you work as much as possible with FHIR first, but don't neglect all the other formats either. That's what we advise you to do. Then the question becomes, is this a data lake? Is this a data warehouse? Is this a FHIR facade? Is this a FHIR repo? Do I need to do a longitudinal record? All those things are possible, and all those things have their advantages and disadvantages. What I can say is that this is a quick view of what advantages and disadvantages exist. I'm not going to go through it for timing reasons. What I can say for those of you who follow the news is that the Grand Hôpital de Charleroi has chosen the road to do it with a longitudinal record, which is what you saw in the little video before, where you have an entire view of your patient from the minute he's born until the minute he dies. So what should you do if you're a hospital and you want to take our advice? My advice is learn to work with FHIR and SQL, pump up that level of knowledge in your establishment, create that central data repository, copied or federated, document and DCAT AP. That's another format that will be very useful for you to at least tell the world what data you have. And then, and this is a Belgian story, make sure you find a way to visualize all that data centrally, because Receive INAMI won't do it for you. Things that you should not do: don't expect the EPD provider to solve everything. Don't spend too much time on Gen AI projects, because the technology is advancing fast and will offer you tooling that will go beyond what you can do as a single hospital. Don't worry about all possible data formats. Do worry about FHIR and SQL. For those of you who would like to have a good list of requirements, we have one in this slide. The slides will be made available for those of you who registered to this webinar. I will be sharing this list of requirements with you. FHIR SQL is there. Vector databases are there as well. That will allow you to make sure that AI is not an afterthought, but implemented from the start. And don't forget that you want to make sure that you're able to do some real life reporting. I end by inviting you all on our conference here in Brussels on the 3rd and 4th of February. Last year it was in Paris on the 3rd and 4th of February as well. Same dates. This year it's a Wednesday and Thursday, where we'll bring together the community who have already done this, who are already working with this, and sharing with you what their experiences are. That's what I wanted to present. I hope I've been able to give you confidence that doing this is possible. I hope I've been able to show you the value it brings as a data user, but also as somebody who's managing registries and making sure that data becomes available for research. And I am now available to look at the questions that may have popped up in the Q&A. Geoffroy?
Yes. So we have two questions. The first one is, how much will it cost in practice for Belgium?
The question of cost is never far away. There is a cost indeed for the software. There's a different cost for linking everything, because it's one thing to have the software. You have to feed it with the data. There's a third cost for the hardware. This has to run somewhere, and there's a fourth element. Once you start using AI on that, you have to manage your token cost over there. If you would look at this, if you would go to full Monty with what you saw in the video for the entire Belgian scope, 12 million people, you'd be looking at a software cost of around 5 million on a yearly basis, and an integration and setup cost of around 2.7 million. So that's 7.5 million euros. That's without the hardware cost or the tokens. 7.5 million euros, which is a lot of money, but at the same time, it's a lot less than the budgets that are sometimes talked about for that kind of implementations. Obviously, if you're doing this on a small scale, a lot of these costs scale down if you're looking to do this on a hospital level.
Another question is about the access to this. That's the question from guest.
The question is, how can we have access to the healthshare.be platform? You'll see if you go to healthshare.be, at the bottom there's a contact us, and if you send a little email there, we'll be very happy to onboard you. It's interesting because it's one thing to have it seen work for the Germans, for the Dutch, and for the French, and there's 70 deployments in EMEA. But it gets really tangible when you see AbriMed data in there, when you see TMP data in there, and we're more than happy to connect your own instance, your own development instance, because this is an environment that is accessible by everybody. We'll be very happy to connect your development instance there.
And then we have a last question.
Last question. Yeah.
How do we begin with this kind of project? Should we start with primary use or secondary use of care?
Yeah, so the question is, how do we start with this? Do we start with primary use or secondary use or different? The answer is start small. There's not one deployment that went for a big bang with primary use entirely in it, secondary use entirely in it. There's different ways to start small. You could start, for instance, with one hospital. That's what we're doing at the Grand Hôpital de Charleroi, and then start adding the network to it. You could also start with one use case. Another use case could be, hey, we live at the border and we see a lot of patients coming from across the border and want to share information with the hospital that is, or with the primary care takers at the other side of the border. That could be your first use case. Then you're not doing it for the entire hospital, but only for a certain subset of patients that are, for instance, the patients that cross the border. Or you can do it with nursing homes. So you start setting up a network between you as a hospital and the nursing homes, because you feel like there's a lack of data transfer between nursing homes and your own establishment. So always start small. When I look at our European Alpha customer, that's Lombardy in Italy, 10 million people. Today they have primary care. Today they have primary care and secondary care connected, but it didn't start like that. It started small. 9 years later, we are where we are today. So start small. It can be primary care. It can be secondary care. It can be primary use or secondary use. Start small is the message. What small means, we'll identify that together with you. So, right. Thank you very much for the questions. Thank you very much for your attention. We'll be looking forward to welcoming you in live on the 3rd and 4th of February, if not before that, and digitally on the healthshare.be platform. Do reach out for your login. Have a great day.